use technology to build connectivity and to create a space where we can talk, argue, analyze, support each other, challenge each other, all in the spirit of building community, building connectivity, building sustainability in our neighborhoods, in our families, and in our community. So with that, Clarence Jones, good afternoon, brother. How you
Thank
doing?
you. I'm doing wonderful. Thank you, Mr. McFarlane. First of all, let me thank you for the opportunity to be here to talk about a topic that our group has been concerned about for a long time. It's the Human Group, which is opioids in our community, and it's one that just quite honestly, I had no real idea about. Somebody approached me once and said that we had an opioid problem in our community. I said, okay, I don't do opioids, so I don't know. I talked to a healthcare professional and I said, well, we're going to be working around the issue of opioids in our community. She said, why? Your people don't do opioids. I said, I don't know. And that's why I talked to the community members. I realized all of a sudden, I shouldn't say all of a sudden, but I kept hearing this common theme is that we don't call them opioids. And so immediately I started thinking about, okay, here we go with crack and cocaine. You know, the challenges that we have with that, you know. And fortunately, one of my colleagues, Mr. Sam Simmons, is who's also will be one of the speakers here today, was there to kind of help guide me through this process. But my concern was that I care about my community. Human is a program that is that listens to the community, and we try to provide information so that we can have a healthier community. Our whole goal is healthy men, healthy families, healthy communities. And so we have started we started on this process about 3 years ago. We started doing lunch and learns. We started doing community forums. We started making connections. I mean, with Miss Hawkins, I mean, we just sat down. She vetted us for a long time. We vetted her for a long time because we really wanted to find community partners that we could work with. Because I knew that if we did not have our own community narrative, that other people will make the narrative for us. And so it was important for us to be able, at least from a community perspective, to have people that we could confide in and can trust in. During that time, I had been working with Dr. Eder on a variety of different things over at the University of Minnesota. And he happened to introduce us to Dr. Munson and Dr. Austin, who are also on this call, to talk to us about a project or talk to us about a program that was called the My Strength, My Health in the Omaha system. Now, we had some previous experiences with that, but we did not know the depth that this particular instrument could do. But we knew that it was something that we wanted to try. And so we connected with them. And over the last 3 years, 2 or 3 years, we have been working, trying to gain the credibility and trying to gain the opportunity to talk to our community and have a honest, transparent dialogue about opioids. Because I don't hear that conversation much. I mean, I hear about opioids, but it's not, to me, it's not really opening up the doors for us to really have this conversation where we can make a difference. And so I care about the community. So what we have done over the last 3 years, like I said before, we have worked very hard to be credible, to talk about this. And so the city of Minneapolis recently gave us a grant where we're going to be doing about 400 surveys in North Minneapolis and some parts of South Minneapolis around what is the community's perception around opioids, but also around COVID-19. The other part that why we're doing these two together is that if you look at the newspaper, you hear about the challenges that people are having because they're isolated. We hear about the challenges that people are having because they're struggling with opioids, and so we want to do something different. Our goal is not to have another program. And one of the reasons why we're excited about this is that we actually have the partners who are going to be here that will be going back to our community and sharing exactly what's going on. So I just want to thank you. I know that's a lot, but our whole goal has really been to have this transparent, honest conversation because we need to be telling our policymakers, we need to be telling our community members what's really happening. And I don't think that we're getting that message. And so I'm going to let Diana go, because I want her to talk about this, because I want people to understand that this is community driven. This is not about the university running stuff. This has always been about the community from the very beginning all the way through the process. We're going to be talking about community. So Diana, you and Andrew can go.
Okay, Diana Hawkins, Executive Director for Hawthorne Neighborhood Council. And as Clarence said, about 2-3 years now, we've been working with this opiates. Clarence brought this to us, him and Robin, through our Northside Urban Coalition, which that is focused around our youth and underage drinking, opiates. Recently, we added trauma, thanks to Mr. Sam Simmons, because he's an expert in that, and the youth really wanted to hear about that, so thank you, Sam. But it's underage drinking, marijuana, the opiates. And so there are so many people that are addicted, and you really don't know that they're addicted. And really all they need is somebody that care about them. And so if we can get that information out and help our people that are out here who are struggling, especially on the north side, in the low income communities, this is really gonna help us. So I'm not gonna talk a lot because, I'm gonna let Robin and Karen and others get to the meat of it, but I'm just gonna let Andrew go ahead. But Al, as you know, our coalition, our focus is our youth. Not only do we need to focus on our youth now, with everything that is going on, we need to focus on everybody, because there's a lot of domestic violence out here now. So that's all I'm gonna say. I'm gonna be quiet for now, but Andrew, I'll let you speak.
Thanks. Yeah, not a whole lot more to add. I just want to say how thankful we at Hawthorne are for this partnership, because we see one thing we hear about a lot of studies or outreach efforts in our community is that people don't feel like they're actually a part of it. They feel like it's being done to them or at them. And so to have this partnership between Hawthorne and Human and the U of M, it really allows our community and our just the people we know and love in our community to be engaged and engage with this effort against opioids, and to learn from them, as well as to also bring them information that they're looking for. And so once again, just I think all around, it's been a really great partnership, and I'm certainly looking forward to seeing where else it can go.
Yeah. If you don't mind, Dr. Munson and then Mickey will speak, and then we're going to turn it to Robin. Okay?
That's perfect.
All right.
Thank you so much, Al, Clarence, Diana, Andrew, everyone. Can't wait to hear from Sam. And just what a privilege it is to be here with you to talk about our work arm in arm around community, around opioids, around trying to understand what's going on with COVID-19 in our neighborhoods. And for me, as a public health nurse for many, many years, and now a faculty member in the University of Minnesota School of Nursing, it is coming home to where the rubber meets the road and really being engaged in community. As Andrew was saying, we are sort of your servants here. We can facilitate having the voice of community come through in our data. And so we want our expertise to be of service to the community. We want to be able to provide data, as Clarence was saying, so that you can use it to influence policy, to influence resource availability, to write a new narrative that shifts from the deficit model to the strengths model. And for the details, I'm going to hand off to Dr. Robin Austin, who is so eloquent about this.
Thank you. Mickey, did you want to go first? Oh, he's saying no. Okay. Thank you, everybody, for having us here. This has been really, truly a great opportunity to talk about this project and to share more about what we're trying to do and how we're trying to bring all of these partners together. So I, too, want to echo and so thankful for the partnership and to be able to come on and talk about it more and more. But I think that going off of what Karen had said as well, and I think back when we started this project, we just thought, let's just go out and have a few lunch and learns. And little did we know, we just kept getting asked to come back more and more, and the project just kept growing and growing. We thought we were going to do 4, maybe lunch and learns. We ended up doing 22. So really it was, I think that spoke volumes as well of people really wanting to have input and insight into this project. And really, truly, when we say community driven, it is community driven. And we're here to help, as Dr. Munson had said as well, to serve. And how can we help? How can we help facilitate these conversations and truly provide the data back to get us the answers that we want, and to really have the voice of the community. And so we're really looking forward to our next steps as well, and working. We have a few graduate students working with us going forward with the City of Minneapolis project. And again, really looking at not only opioids, but also COVID and the impact on community, not just looking at it from a problem or a deficit, as Dr. Munson had mentioned, but really, what is our resilience? What are our strengths and assets that we bring to the table to really help shift that conversation around what is happening in our community? Look at, these are the things we're doing really well. How can we leverage that to help offset some of these other challenges that we also see happening in our communities? And really having, I think that allows us to have a little bit of a deeper, more meaningful conversation as well. That's kind of from our past experience, we found that. So we're hoping to really build off of some of those things that we did as well. So the tool that we're going to be using, as Clarence had mentioned early on, is called My Strengths, My Health. And this is a mobile health web-based application. Dr. Munson and I had an opportunity to create and work on for the number of years, but we're trying to bring this out to the community. And the language in the application is community validated. We had a meeting a few years ago with Clarence and of some of our partners out in the neighborhoods, and trying to make sure that the language in the app is representative of everybody, and that we have the ability to have a conversation and to have things in your own perspective, in your own voice. So we're going to be using My Strengths, My Health, as well as another opioid survey we had created from the previous project, to really, again, give us a broad kind of idea or scope of what is happening out in our community, and to be able to use these 2 tools in partnership with our community partners to help spread the word about what is going on. So
Robin, if you want to, you're welcome to screen share if you have graphics or visuals.
Sure.
Yeah, if you want to.
Okay, I can do that. I'll just, I'll pause while I get that up, and then Dr. Mickey or Eder could say a few words while I get my screen ready.
Okay.
Thank you.
And I'd just like to say that after Dr. Eder speak, I'd like Sam to just speak, because Sam is a part of Human, and Sam is our resident expert, and Sam is the person that really helps me to stay on track. When I'm off track, Sam helps me stay on track. And if you know Sam, you know that. But I think that he can speak to why we are, from our perspective, why as a community, we need to be really looking at this issue a little bit closer. So Dr. Eder and then Sam, okay?
Good afternoon, it's Mickey Eder. I just want to acknowledge that we're here to support and listen. I think Karen said that. We're trying to transform our university relationship to the community. We acknowledge Human has been around for a decade, and it is just a privilege. And really, the key factor is we are working with community leaders and people that have dedicated not just a few weeks or a funded projects amount of time to improving the health of the community, but have made their life's work improving the health of the community. And without our ability to work with you and to learn from you, none of this would really be happening. So thank you.
Thank you.
Mr. Simmons?
Well, I want to thank you for allowing me to be here. My connection to all of this is through Clarence. He brought it to me in terms of some of the conversations he were having with different folks with the university in the community partnership with Hawthorne. And my background is I'm a licensed chemical dependency counselor, been licensed ever since the state decided to license chemical dependency counselors, I think for the last 20, 30 years. And I also have a background in chronic pain. I worked at Abbott Northwestern Chronic Pain Clinic for 20 years. And with that background, we dealt with a lot of opioid use. And in the chronic pain clinic, majority of our clients were white. And one of the things I noticed is that we didn't have that many clients of color. But the other thing is, when we did have clients of color, they were treated differently in terms of our white clients. They were always treated like, when it came to opioids, like they were addicts. And the studies have shown that African Americans are less likely to, than their white counterparts to become, that's probably changed a little bit over the last few years, but at that time encountered opioids through painkillers, because their doctors would challenge them in terms of being able to get their medication. And one of the examples I dealt with closely was one around sickle cell. We know that sickle cell patients would have episodes and need, during the episode, would need increased amounts of medications, and they would get challenged and chastised in emergency rooms to get that medication. And I had a client of mine, personal client of mine, that I had to literally go to the emergency room and fuss with the emergency room doctor to get him the medication he needed for his episodes. And because I had a connection with his personal doctor, I was able to make that happen. And so the idea of opioids was more in that professional level. And then we take 20 years after that experience and that kind of thing, then we have this all of a sudden resurgence of conversation about opioids. But we have to understand, during the chronic pain clinic era, they started having chronic pain patients go to methadone clinics to deal with their chronic pain, because they had shut down chronic pain clinics. So you were setting up folks to be addicts, right, in the name of health, and which was bizarre to me. How do you go to a methadone clinic, have people go methadone deal with their pain? And so they closed down our program in 2005. It was the last of the what we call behavioral modification clinics, basically taking people off of medications and monitoring their behavior and those kind of things. And then we went to the new pain clinics, which what I call injection clinics, which basically did a lot of steroid injections and those kind of pieces, and then would add the opioids. And then when the clients they deemed as abusing the opioids, they would cut them off, and then they end up at these methadone clinics. And then later on, they, not dealing with the whole scope of managing pain, which is a psychological and physical scope of that. That's what we used to deal with in our program. So trying to give you a little history, background history on some of the stuff I was exposed to. And so when they brought this to me and talking about having conversations with the African American community, and, the thing was, opioids, big thing, and all the faces were white in the conversations, right? And which, was interesting and, seemed a little weird. And, and folks would literally, I remember I was in Milwaukee for a conference, and there was a professional out of DC, white individual. I walked into his presentation. I had just got finished with mine, and he was in there talking about opioids. And you know what he said? He said, well, you African Americans should be glad, be lucky we didn't prescribe you as many medications as we did the whites. He was literally bragging about that, right? He didn't fill in the fact that that's because you treated them all like addicts. And so I went to the person who put the thing together. I said, are you understanding what this cat is down here talking about? And I mean, they were paying him big money to come in and talk about the opioid crisis. And this is what was being said to people. And so the thing is folks say, well, African Americans don't use opioids. And, we got the issue around cocaine and crack and that kind of stuff. And the issue is African Americans, when they think of opioids, they didn't realize that we're in our community, we're talking about heroin. So, and not being able to connect those dots. That's why these conversations are important, and survey is important. When you think of opioid, what do you think about? And letting folks tell you and have people listen for the first time. And then the other complaint was, in terms of the professional, was When we talk to the Black community, all they want to do is talk about crack. That's because that's not done. The repercussions from the crack era, when you use policing as a way, instead of treatment as a way to address crack, still has repercussions to this day. And all Black folks want you to do is say you sorry and admit to your wrong. And if you can't sit down and hear that, then you can't sit down in our community and have a conversation with us. And so those are some of the other conversations. And then when we're talking about opioids, we really have to talk about, because of the crack era and the distrust and the mistreatment from that, how are we supposed to trust professionals coming in our community, having these conversations and thinking they really care? Another thing is in 2017, we accidentally heard about, and I say accidentally because that's the way it felt, heard about that African Americans were dying at a higher rate of opioids than whites, even though they were a smaller population. And the people who gave out the information, threw it out there all willy-nilly. And it's like, well, where is this information? And they said, well, it's on this site, on that site. But why ain't we talking about that with the Black community? Why aren't we talking about why that is? And part of why that is the distrust that the community has with systems, the availability of the different kind of medication, naloxone and those kind of things. And the African Americans don't trust the law, the Good Samaritan law, which means that if I find somebody who's overdosing, that I can stick with them and call somebody to help them, like the ambulance or and not be prosecuted. We don't believe that because that ain't the way it's done. I've had experiences where folks who have called and still got charged. And so the idea of laws are being treated fairly was a myth in terms of the community. And so basically what folks was doing is they would be using with each other, and then they would leave their fellows or partners to die or go, leave the site and then call, which might be too late. And unfortunately, I have a personal friend that's actually what happened to her son. So my involvement is really in the background to talk about these extra pieces of examples around opioids, so that it helped at least with how the survey is presented, which has went through a long vetting process, which without these voices, it would have never happened.
Yeah. So I want to say right now that thank you, Sam, for that, because that's really it. We're going to disseminate whatever information we learn. We're going to disseminate it back to the community. I think that's going to be one of the things that's going to happen that we have already made sure would happen, that we were, within a short period of time, we're going to process it and give back to the community at least 4 different times what we're learning. The other part I want to share with you, and I think Robin will bring this up too, is that we're trying to look at this from a holistic perspective, not just the drugs, but also the health of people, the relationship with people, grief. I mean, there's a variety of things that go along with this particular issue. We want to be able to at least enter into the conversation. We know that we are not going to have, this is not $1 million project, okay? But we're gonna work this thing to the best of our ability to give our community its own voice and narrative around this from what we learn, so that we can make some decisions. That's all we want to do. And so that's one of the reasons why we've had many of these conversations. So Robin?
This is wonderful. Yeah, Robin, maybe you have ready to do the screen share.
Yep, I can certainly share my screen. Absolutely.
Let me jump in for a second though before you do that,
Sure.
just to give you some feedback on what I've heard so far this morning. And I can tell you that what you all have presented is absolutely phenomenal, excellent. And I want to just say on my own behalf, as a newsman and news reporter, and on behalf of the people that are going to read about this and hear about it, thanks to all of you. I want to thank the university team, the partners, because of their consistent emphasis on being of service to our community, and for a project to lead with that declaration of intent that we have knowledge, we have experience, we have resources, but our existence is to navigating its pathway to health. I think that's huge, and that's different from the way things used to be. Time will tell if you deliver on the promise, but it's a promise being made that's being received. And our job, my job as a communicator, is to present the promise and the possibility of equity and equality being the guiding forces underneath the work and research that you're doing, and that surrounds the deliverables, the data that you present. I want to go back then also to the comments by Brother Sam Simmons, just mind-blowing and rich and full, and also tearful and hurtful because of the power of the truth that he is presenting and describing to us. You know, the personal stories, personal connectivity, but knowledge that is indisputable, facts, history, stories, but reflecting how the institutions have consistently failed to respond to truth as we've presented it, and consistently failed to honor scholarship, knowledge, capability, and intent and desire to move the necessity of healing away from institutions, but into the community, and that means even into individuals. Healing begins within, and I think the model that Sam Simmons and model that empowers individuals to discover their role in healing themselves and healing the community. That's what I hear and I see. And Sam, you know, and then to Clarence, some people have heard me say a lot that in the business of health, the business of data collection, the business of research, the business of service delivery. Sam talked about being in a conference, and that the expert on opioids, a white guy from DC, speaking kind of dismissively and arrogantly about why we should be glad they didn't prescribe opioids to the Black community. Well, you know, that really speaks to the criminalization of Black pain. Black people's pain is criminal, and therefore the response by the institution is law enforcement and jailing. White people's pain is something that we have to all be concerned about. And there is example after example after example of institutional racism and policies and practice that keep our people at the margin and prevent us from delivering our own health and healing. Yet we are resilient, and for this project to say my strength and my health is a project that is seeking to explore not the deficiency, but the resilience, the solution side of our involvement, and us as part of the solution. I think that's rich and that's wonderful. So those are just some reactions and reflections so far. If I'm off, please challenge me and explain where I'm missing the boat. But I'm glad to have this conversation. I think it's an important one, and I see this as something that we're going to keep doing as long as we need to, and that's going to be forever, because our health is permanent like that. So Sam, let me know if I'm on track with this, and Clarence, let me know if I'm speaking in ways that make sense for you. So with that, let's go ahead back to Dr. Robin, and you know, I see the screen share is up.
Yep, the screen shares up. Thank you so much for that wonderful recap. You're absolutely, from my perspective, you're spot on as well. So it's very, very nice to hear as well. And I wanted to, as we go through the My Strengths, My Health, I'll kind of refer back to some of the comments that Sam made, as well as Clarence, and that having input to create these the surveys and having that input and insight into this has been really, really helpful and phenomenal. I think it's really been able to us to all of us to have a conversation. So I really, truly appreciate that context that you put that in. So we're looking at the screen that says My Strengths, My Health. This is the first screen that individuals come to when they come into the link. And I'm actually on the My Strengths, My Health, the instance that will be within the Minneapolis project, Clarence, if that's okay, so they can see, it'll look exactly the same. So it's somewhat familiar. We also have resources for COVID-19 on there as well, for that, just for reference as well. And you'll come to a demographic page, and again, I just want to reiterate that the data is de-identified, meaning we can't re-identify who you are. It's anonymous, all of those things. But we're asking people to enter a postal code, which I'll just put in a quick, some kind of what they call fake data, and I'll just put in a test, just so I know it's a test. But we're asking how many people live with you, how many days a week do you come in contact with others, and we have demographic questions down here below as well. We're asking people to fill out if they feel comfortable doing so. But I'm going to click continue so we can get into the application itself. And this is going to refer back to what Clarence had mentioned, that we're looking at opioids and the COVID around a holistic view. So meaning that they're, again, looking at things from not just a one perspective, maybe physiological issues or some physical symptoms, but really what is the holistic, what is the whole person? We are a part of where we come from, we're a part of where we live, we're a part of our health behaviors. So we're trying to look at it from are 4 main areas. One is called My Living. One is called My Mind and Networks, which is the mental health, psychosocial, grief, loss, which Clarence had also talked about. My Body, which is your physical symptoms. So here we're looking at pain, and also consciousness is meaning of how awake you are, if you're very, very tired, things like that. And then My Self-Care is how do you, your health-related behaviors. So we have substance abuse and sleeping that we're also asking about. And just I'll pause for just a second and say the thing about sleeping that we've noticed is that it's not only know it's extremely important for our overall health, but just that it's tied to so many other things that we're now finding out within overall looking at health in general. But when we also talk about from our previous work, Sam had mentioned that really being able to refine and fully vet the survey that we had used in our previous work. One thing that really did come out is mental health and the ability to talk about mental health, the ability to have mental health resources. So we're really trying to understand that as well within the context of this project. And I'll pause and just ask for comments from either Karen or Dr. Eder or Clarence if I can go into anything specific that you're looking for as we kind of walk through the app.
I think that one of the things I want to say is that we actually talked to the community. The community selected these topics. There are 42 topics that we could have selected from, I think, 42 pieces, but these are the ones that really came out, emerged that the community really wants to talk about. And especially, it was interesting, the one about pain. Initially, that was not a part of the ones that we were presenting, but said, no, we need to talk about pain. So, which gets back to what Sam is saying. So that was something that they want to have their own narrative around. And that's what I think is important.
Yeah, so thanks for bringing that up. I had clicked on the pain concept within the application just to show what that looks like. And so we're asking individuals to describe your pain. And so it could be very bad, all the way up to no pain, or your pain is good, meaning it's very little. And so far you're doing okay. But we're also asking if you do have pain that's bad, we're asking, are these any of these other pieces related to that? Are you having pain right now? Are you potentially restless because of pain? Is it hard to move because of pain? And you select these in this area. You just select it if it applies to you, and then you leave it blank if it doesn't apply to you. But in addition to, we're asking not only are more deeper conversations about pain, but what are your needs around pain? So maybe you want more information and guidance on that. Maybe you want someone to check in with you around your pain, or potentially you want someone to help you coordinate your care around pain. So we're wanting to know from the individual's own perspective, what do you need around this concept of pain? And on this scale up above, I forgot to mention, if we're rating a 4 or a 5, we consider that as a strength for that individual. And so I'll just click finish and go to another concept. I'll use connecting. So how would you describe your connecting? And so maybe for you right now, it's okay, but you also have there are some things that you don't like your services, or there's not enough services. I'm just kind of making it up as we go along. But again, in the middle here, we're asking a little bit more detailed conversation or detailed about your connecting, and then wanting to know again from your own perspective what you might need around this issue. So maybe you want, again, more information about how to connect with your services or connection within your community, things like that. So I'll finish there as well. Let's see, I'll do one more, and then if we have time, I can go to the report page as well to show people how to get the report. So we'll look at sleeping, and I'll say my sleeping is very bad, and that I wake up a lot at night, and I can't get to sleep. And then I really want some information about that and someone to check in with me about that. So I'm going to click finish. And in a real assessment, you would go through all of these on the left-hand side, as you see. And after I've been there, it turns a different color, so you can see that I've already completed that specific concept. I'm going to move there. So when you're done with all of them, they'll all turn a different color, so you can tell that you've been there. I'm going to click on this, what's called the report button. And so this will come up and show where I didn't finish anything in my living, so it's blank, but you can see where I have completed some of the assessments, where it shows me my average rating, how many problems I have within that one specific bucket called My Mind and Networks. And then if you scroll down a little bit further, and I apologize for scrolling, it has it listed here as well in Word format. So you can see that I rated my sleeping as very bad. I say that I wake up a lot at night and I cannot get to sleep. I really want someone to check in with me. And then I say my pain is good, but I'm also saying it's hard to move because of my pain. I might be restless because of my pain. And here are some things that I need about that as well. And the one thing I did want to show before we open it up to more comments and discussion is this button here. It's called Submit and Print Results. So when you hit Submit and Print Results, the individual is taking the assessment. You'll see a code here. And this code allows you to go back in and see your answers at a different time. If you just wanted to be done, you could be done, but write that code down. You can go back in and look at your assessment at a later time, just to read over it again. But here down below as well, we have the ability for you to print your personal report. Oops, I won't do that right now. But you have the ability, this page here, where it says domain, strengths, challenges, and needs, that the individual, you're able to take that and print it or save it as a PDF document. So you can save that for a later time. You can print it yourself, bring it in if you'd like to do that, or just keep it on your device and keep it there as well if you'd like to do that. So you have the ability to go back and really look over again, what did I answer and how do I want to talk about this? And really being able to share that with healthcare providers or friends and family, caregivers, things like that. So again, I'll pause there one more time and ask if Karen has any other comments, or Clarence.
I just want to say one thing, that I like this because this can actually, they have a heat map that can actually talk about things versus neighborhood and zip codes. I mean, so every zip code might not be the same. There might be different needs in a zip code. It's there. The other thing I just want people to know is that we're asking people who are really committed. We're going to give you $10 to take the survey, okay? But it's not about the money. It's about really getting people who really care about the community, or who really have a vested interest in making sure that we get the kind of information that we need. We're going to make sure that we are fully transparent with everything. So those are two things I want to say.
Yeah, great. Thank you. Karen, do you have anything to add as well?
Sure. So there's no end to the implications here, because once a person has a full, comprehensive, holistic look at their own health and well-being, this just came home to us when we were in our research previously with Clarence and Nikki in the community. This is powerful news. This is powerful information. And it's really important that we see ourselves with all of our strengths, as well as where the areas of need are. And this becomes a care plan that we can say, this is what I need and want in my healthcare. And this becomes a tool for talking with family about, I'm not doing so well, or I'm, here's, look at all I've got going for me. And thanks to you, thanks for being my family. Also for our study in Minneapolis, we're going to have a dashboard that will be able to show us the entire, like, what's going on with all the aggregated data that'll say, here's where our main strengths are. And I'm just reminded of the previous comments about resilience and how important resilience is, and how, despite everything, community is a strong, strong place to be. And people of color have so much resilience, and just, honoring that and making sure that resilience is transparent. And we've been able to do that with our data. We've been able to show that living in our neighborhoods and our communities makes us stronger. And
Can I ask a question?
Yes, please.
If I may. My name is Etrophic Burnett. Good afternoon, all. I have questions. First and foremost, I'm wondering, is there not enough data? Because I am a product of heroin being in my community, as Mr. Sam Simmons said for a long time. My dad went to the Vietnam War right along with my uncles, and they came back addicted because they dropped them off in the poppy fields, right? And so, and I understand that now it is epidemic because it has hit different ethnicities in a different way than it has always been in my community. My dad was addicted. Everybody around me was addicted. It was called smack. We knew what was going on. We knew heroin was in our community. We also knew not to mess with it, right? But that was some of us who was addicted, right? We also know that that it's still in our community, right? And prior to it becoming an epidemic, heroin was always in our community, right? And so I have some concerns and some questions about the survey and the data, because we already know that heroin hit our community big in the 70s. And then when they turned around and gave us crack, they gave us babies Ritalin, which had a form of heroin in it. And our babies now, why they on Molly's, why they on Percocets, why they on Oxys, is because the healthcare field decided to give them this as babies to overcome crack, which the government gave our communities. And so, just like Mr. Sam Simmons said, there's no trust. I'm concerned about as far as the language is concerned, because we at a point where we beyond so much as far as painkillers. We on fentanyl, right? So everybody know these painkillers, they come here, they fake, they got fentanyl in them. Everything right now got fentanyl in them. Everybody got fentanyl blocks. Northside got fentanyl blocks. Southside got fentanyl blocks. They call them Fenny blocks, right? So when we talk about opioids, we can't talk about opioids without talking about the inequities in the healthcare, the inequities in the economy, the jobs, housing, and how it's all interconnected, and how it's even connected with public safety, right? So, when I look at the fact that I buried my godson, I'm praying to God every day I don't have to bury my ex because he's on it, because it was heroin. My uncle overdosed on it. And I'm studying how to bury people because heroin been around and they've been shooting it before Oxys and Perks came out. And so I'm a little bit concerned, and I don't know if I'm just taking this personally, because I see the young lady that walk up and down Broadway, and she was a college graduate because one thing changed her whole life. And now she's out there, and she was a college graduate, and now she's out there walking the street. And no one said nothing to that young lady. So I'm a little bit emotional because I see my young people who's struggling with gender identity and they go to drugs. I see the East African communities who don't even know how to talk to their children about being addicted right now. I had to save a little boy up there Holiday, and I stayed with him. I stayed with that young boy up at Holiday because he was having the overdose, and he was East African. And so I'm saying all this to say that there are a lot of different tools that we need to use to come together to combat this epidemic, and a lot of the language have to be also culturally specific, because our Asians, it's attack our Asian community at a high number, as well as our East African community, as well as our Black communities. And it was never talked about. We just buried them. So there are a number of tools that we're going to have to get together in order to combat this, because this is also a part of public safety. Our young men and women are lost. They are lost. They are lost, and they don't care about taking a chance on getting a perk or oxy that's laced with fentanyl. They don't care, because they don't want to deal with the fact that they was born in DCFS. They don't want to deal with the fact that they was in jail and can't get a job and highly mobile. So they take a perk, they take an oxy, and they put that mask on. That's what they call it, a mask on, mask off. And then we got their daddies out here bent over, can barely get up off the floor. Because why? Because they out here at 4 o'clock in the morning trying to get their sick off. Our community call it sick off. 4 o'clock in the morning, you can walk up and down Broadway, you're going to see them. You can go right over here to Knox, right behind the police station. 3 or 4 o'clock in the morning, they got to get their sick off. So it's a difference when it comes to, I know, our community, and the fact that now that we don't have crack, that crack has minimized and heroin and fentanyl has maximized. In my community, when they say somebody died off dope, guess what? Everybody and their mama out there looking for that dope dealer, because they want the good dope. So it's like, I get the survey, but I also get that there has to be a language, and it has to also be culturally specific, and it has to be whereas, we're not just asking people how they feeling, because moms are hurting because all their kids got taken away from DCFS, and they've been on drugs, and they've been shooting heroin. They started out sniffing it, and now they're shooting it because they lost all their kids. Or their boyfriend told them, come on, it's going to get your sex drive up. That's what happened in our community. So it's not so much. And then, just like Mr. Simmons said, when we showed up, it was like we was drug addicts. Even when we got into a car accident, my daughter sat here, broke her foot, got 3 rods in her foot. And they gave her 3 pills for pain and told her she gonna be all right. And they put 3 rods in her foot. But because the statistics say that Black women have a high tolerance for pain, that they don't want to give us nothing. But they so quick to cut us when it's time to have a baby. Yep. We got a high number of women that get cut that has cesarean when they have babies. So I think that when we talk about this, we got to talk about all of it. The inequities, the mistrust, the institutionalized and systemic racism, all those things that has taken place to make us self-medicate. That's what my community has been doing, self-medicating to survive in this world and in this country that wasn't, and then in the laws and policies that wasn't existed for them. They medicating themselves because of the hurt, the pain, the distrust, not getting a job, not having housing, having been redlined for years. So I think it's going to take a number of tools for us all to bring our brilliant minds, our resources, and our network, because this also plays a hand with public safety, also plays a hand with housing. You think that's why we got all 350 people out there in camps? It's not. So I just figured out, like, if there are a number of tools that we can do, because I can see people taking a survey for $10. I can. They're filling out the survey. They can go get their quick morning stick off for that $10. But our communities have had so many surveys and sucked up so much of our intellectual property and have not given us anything sustainable to move forward. Not a subsidy, not Section 8, not a subsidy, not a Band-Aid, sustainable resources, because it's going to take us years, because our babies are getting addicted the younger they are. If they continue to go over needles, they're going to eventually pick up one and use it. So we need sustainable short-term and long-term goal in this. And how we're going to bring on all of those tools, not just to fit one, and to really have those hard conversations about the inequities in the healthcare field, the inequities that prevent us from getting whole. Because we'll fake it. but what actually prevents us from getting real whole. Yeah. And I know Mr. Sampson, because I believe in talking about core hurts. How we talk about those core hurts that got us to this, how we talk about that trauma that we live every day in our minds, that somebody told us that I wanted to be an artist, but somebody told us that I wasn't going to be nothing, that led me to the heroin. And talk about it in the way that Caucasians say opioids, and we say heroin, dope, smack. So it's all about the language, because the language has always been a superior tool that's been used against us too, to keep us out. So I'm just wondering how we do this. We have to use a number of tools so we can help all of our people.
Ethropic, let me jump in. You know what, your testimony, that's what I call it, both makes me angry, sad, tearful, and at the same time gives me hope, because the analysis that you bring is so clear, so sharp, so illuminating, so truthful. And so if we have the ability to tell our truth to ourselves and to the world, that truth will free us, I believe. I am hoping. And so the question to the researchers and to the project, in part, is data to what end? What's the end game? As we produce and collect this information, is part of our strategy to say this is how we're going to affect public policy. So we're looking at health, we're looking at employment, we're looking at housing, we're looking at all of the, they call them the social determinants, right? Yeah, right. How do we, with intention, create as part of the plan change? The goal must be transformation. And the transformation we're talking about is one that recognizes, that sees us, recognizes us, that sees us and supports our commitment to us being fully engaged with agency for our own future, our own health, our own community, and as part of the and participants at the table of decision in society. Sam, why don't you go from there, if you would, and just build on and further contextualize what Ethropic so beautifully said and what I'm saying now, Brother Simmons.
Well, I can't really answer the full question of where we go with the information. I'm not as privy to that side as the individuals with the university and Clarence, but what was brought up, this whole issue around trauma, and my other background, when I'm not doing work around chemical dependency, I probably do more work around historical trauma. How have systems ignored the trauma because they don't want to talk about it, and how we as a community haven't realized that we're suffering with trauma, and how do we have a conversation about how that trauma has really elevated our drug use, and in which is really the reason why I haven't practiced chemical dependency in the last several years, is because majority of the programs that we as people of color get shuffled into, that are usually not led by us, do not allow us to address the trauma that we experience. And one of the ones that's the more common talked about now is the whole issue about racial trauma. How do I deal with the overwhelmed anger of not feeling like I have no control over anything? And how do I medicate that? Because historically we have used drugs to medicate our trauma so that we wouldn't kill every white person we ever seen. And so people don't realize how much we have medicated ourselves enough so we can go to work, and medicate enough for us to be able to meet the artificial challenges that was given to us by mainstream that we could never live up to, but was always asked of us, right? And so I call it survival stress management. And the problem with what we got going on now with COVID-19 is we've been ignoring this stuff inside the community and outside the community. And COVID is like almost a cleansing in terms of we cannot ignore it. And now we're so overwhelmed because it's all at once, and now we can't handle it. both internally and externally, because we cannot continue to lie to each other about what's going on. And we can't even lie to ourselves. So when we talk about the increase in domestic violence, the increase in terms of community violence, that's all because we've had young people who have went past resilient, right? We want to talk about resilient. We always want to use the word resilient, and systems get on my nerves to talk about us and resilience. I mean, I have a real problem. You know, I know this is going to be counter, but I have a real problem with this whole term of resilience when people were not supposed to be resilient for 400 years, not have nothing change. Now we're down to survival. Our generations have looked at us doing all the right things, dressing right, getting all the education, and still not getting the benefits from all of that. And so the young people are to the point where they really don't care, don't know how to care, and we're not listening enough, both externally and internally. So if I don't care about my life, why do you think I care about yours? And if I've been convinced over the last 20 years that I'm not going to live past 20 years old, I asked a bunch of young people, if you get convinced that you ain't gonna live past 20 years old, what you gonna do? Well, Mr. Simmons, I'm gonna get all the money, I'm gonna have all the sex, and I'm gonna do whatever I want in that short period of time. And so if we can't be real about that kind of stuff, and I know the survey is just a beginning, right? But as the young lady said, if we go into the vaults of Wilder and University of Minnesota, we'll find so many surveys that was done on our community that a lot of these answers have already been there in terms of the issues. And we have done the surveys, got our little food cards and certificates, but as she said, what has been the sustainable outcome? So I understand the reluctance, but at the same time, what I see that's different with this particular one is I believe that we've been listened to, right? So unfortunately, we're starting now something that should have been started way back. And I can understand the frustration that the young lady's feeling when we're having conversations about opioids when we've been living with smack, right? And we were living with this stuff. And she's right. In 1970s, we had all these brothers who were dropped off in the community high on heroin. And the difference is we didn't have as many women high on heroin as we had men, which kept our kids safe. Crack cocaine, we're still not recovered from crack cocaine because crack cocaine affected our women. And so our babies didn't have nobody they could trust. And them same babies are 40 years old now who haven't learned how, their kids haven't learned how to trust them. And so we got a mess that's internal and external. And because of the distrust, it becomes even more difficult and increases the need to medicate myself to have my 20-minute vacation.
Dr. Eater, jump in.
Yeah, it's Mickey. Thank you. I agree with the comments that have been made and want to make a distinction between data and information. We're collecting data. We are trying to work with the community to transform it into information. And in other words, what does the data actually mean? What I'm hearing is we may not be asking the right questions, or we may not be asking enough questions. Our initial goal is to bring the information from the survey not to the community to tell them what to do next, but to talk to them about what they think it means and have the community help formulate a response. It's a participatory strategy. I think that it reflects a newer understanding that what we've been doing for 30, 40, and I stand corrected, 400 years, hasn't exactly been working. So hopefully conversations like this going forward will help generate insights into successful responses.
I just want to say real quickly, I really appreciate, Ms. Burnett, your comments. I do. And I think that part of why I'm excited about this is that this is not a survey on us, it's a survey with us. And I really believe, and I think the other part too is that I said this a little bit earlier, is that I, along with many other people, have worked hard to be able to earn credibility in the community so that when I say something, people know it comes from the right place. I mean, I've been around for a long time, and I haven't been around, puffing myself up. I've really been around trying to make a difference, and that's really what this is about. I wouldn't work with the university if I thought that they were not real. I mean, Diana and Mr. McFarlane known me a long time. I mean, so it's not a game for me. This is serious. This is serious for me. And Sam, Sam and I go back a long way. I mean, so you got people around in this group right here who have long credibility and history with positively working within the community. It's not a game for us. We need to make some changes. I can't change the world and I can't save the world, but I can just do what I got to do. And part of what I got to do is to try to make the community better for our children. And that's the only thing I'm going into. Like I said, I'm not trying to impress nobody. I'm just saying, like, hey, we need to do this. And there are going to be people like you who will step up to the plate. That's what we want. You have the narrative. That's what we got to have. And if we put the narrative, the data together, the information together, we probably can make some changes. That's all we can do. So I don't want to sound.
Yeah, this has been a wonderful program. Diana, we're at the end of the hour, but you might want to summarize and say what experience, and thanks to the doctors, Mickey and Dr. Robin and Dr. Karen, for being here and doing what you're doing. Andy, you haven't said anything yet, but you're welcome to jump in and make a comment before we close out. Any thoughts, Andy?
I'm just, I'm blown away. This is something that is I'm learning so much. Mm-hmm. It's really impactful. I'm over here, I'm wiping my eyes, and I have a lot to learn as a person who has had a different path. I have a lot to learn, and I think that this project is really going to help us learn what we need to do to help your community. And I really like what Clarence said, is as a survey, not on the community, but a survey with the community. And I really think this has a lot of opportunity to create really positive change. And I hope that what comes out of it is enabling that to help within the community. And so I'm just blown away, and I'm really grateful, and I'm so happy I could be a part of this, because
thank you for being
this
here.
is really, I've learned a lot.
Yeah, Diana, why don't you wrap it up for us if you would, and talk about next steps.
Let's see, Clarence would have the next steps, but we are going to roll out the survey. We hear you. I want you to know that this is my second survey. I had the same questions you had during the first survey when Robin came to me. I'm like, this woman is crazy, but it was worth it. Next steps, the survey is going to roll out, so stay tuned. Any other thoughts, Clarence? That's all I have to say.
Clarence, how many people do you want to reach with the survey?
400.
What's it? 400, and what's the time frame?
We're talking about 3 to 4 months.
Okay, great.
Yep.
All right. And let's give people a phone number, a website right now that we can post with the story if they want to join the survey.
Okay, well, they can call my number. Okay, 612-759-2170. They want to know more.
Okay.
612-759-2170.
Great. Any more comments so far? Listen, I want to just say thanks to all of you. Go ahead.
Will you have outreach workers as well, Clarence?
We do.
Thank you.
We do. And that's what we're looking for. We're looking for, we got all that. And I want to say one last thing. Mm-hmm. We got money from the city, but most of the money goes to the community.
To the community.
It goes to the community. I mean, it was always set up to be community driven, community focused. So, and it's a very transparent process. So yeah, it ain't about the university gets some, human gets some, but the community gets the money. So which is different.
Big difference. I'll end on this note. What I was going to say in my last little monologue was that I've often said that they get the money, we get the misery. Our misery becomes a business for them, meaning white people get the money studying us, and we simply offer our misery as a income for them. So if you're changing that dynamic, it's the right thing. And our allies in the professions in the university, hopefully they will hear the clarity of our criticism and agree with us that we have to change the equation so that the equation focuses and is weighted on our participation on the solution side of the equation, not simply being the problem that's being marveled at. Listen, with that, we're going to close. This has been a wonderful,
thanks, Ms. McFarlane.
Wonderful conversation. We'll be doing more as we go forward, and I invite all of you to stay connected with conversations with Al McFarlane. If you're listening, watching on Facebook Live, like this, leave comments. If you're checking this out on YouTube, send us comments back. We want to extend this conversation and make sure that we all have a chance to bring our voices to the table. I'm Al McFarlane. We'll see you next time. Thank you.